Welcome back to Future CRNA Learning Solutions Pharmacology Series Lectures. Today, we're diving into one of the most important pharmacologic classes in anesthesia, opioids. Opioids are not just pain medications. They are tools that allow us to control the patient's physiologic response to surgery. As anesthesia providers, we are not simply treating pain. We are controlling stress, hemodynamics, ventilation, and overall patient stability. Understanding opioids is foundational to everything we do in anesthesia. So, what do opioids actually do? Opioids work primarily by activating mu opioid receptors in the central nervous system. When these receptors are activated, pain transmission is inhibited. Neurotransmitters like substance P and glutamate are reduced, and the perception of pain is significantly decreased. But here's the key. Opioids don't just block pain signals. They also decrease sympathetic response, reduce heart rate and blood pressure responses, and blunt the surgical stress response. This is why opioids are used across the entire perioperative period. Opioids are used in all three phases of anesthesia. Before surgery, they reduce anxiety and pain. During surgery, they control hemodynamic responses. And after surgery, they provide sustained analgesia. Think about intubation. Without opioids, the heart rate spikes, blood pressure increases, and stress hormones surge. But with opioids, you have a smooth induction. You have controlled physiology, and you have a stable patient. That is the power of opioids in anesthesia. Next, let's talk about the benefits versus risks of opioids. Opioids provide major benefits, such as excellent analgesia, reduced need for inhalational agents, and improved patient comfort. But they come with critical risks. Respiratory depression, which is the most important, bradycardia, and hypotension. This is why opioid use requires constant monitoring and precise dosing. This balance is what separates a good provider from a great one. Now, let's get into specific opioids. Fentanyl is the most commonly used opioid in anesthesia. Key characteristics are that it's extremely potent, 50 to 100 times stronger than morphine. It has a rapid onset within 1 to 2 minutes and a short duration, which is ideal for procedures. Mechanistically, it's highly lipophilic and it crosses the blood-brain barrier quickly. For clinical use is during induction, intraoperative analgesia, and blunting the intubation response. But remember, fentanyl can cause respiratory depression, bradycardia, and mild hypotension. So, dosing and monitoring are critical. Next, we have morphine. Morphine is very different from fentanyl. It has a slower onset, a longer duration, and more side effects. It's ideal for postoperative pain and chronic pain, but key drawbacks include histamine release, leading to itching and flushing, hypotension, and respiratory depression. Also important is that morphine is renally cleared. So in renal failure, you have metabolites accumulating, leading to an increased risk of toxicity. This is a major clinical consideration for morphine. Hydromorphone, or Dilaudid, is a more potent version of morphine. Key advantages are that it's 5 to 7 times more potent. It has less histamine release and a faster onset. It's commonly used for severe pain, postoperative management, and patients who don't tolerate morphine. However, it still carries risks. Of course, again, respiratory depression and sedation. But overall, it provides cleaner, more predictable analgesia compared to morphine. Remifentanil is unique. It is metabolized by plasma esterases, not by the liver or kidneys. This means it has a very rapid onset, a rapid offset, and no accumulation. This makes it perfect for TIVA, neurosurgery, and cases requiring rapid wake-up. But the biggest issue is that pain returns immediately when the infusion stops. So you must transition to another analgesic before stopping it. If you don't, the patient wakes up in severe pain. That is critical to understand with remifentanil. Moving on to sufentanil. Sufentanil is one of the most potent opioids we use. Not as common as many of these other ones we've talked about. It is 5 to 10 times stronger than fentanyl, and it's extremely effective at low doses. It's used in cardiac surgery, major cases, and ICU sedation. Key advantages of sufentanil include being very stable hemodynamically, but there's a high risk of respiratory depression and it requires very precise dosing. This is not a beginner drug. It requires experience and careful titration. In modern anesthesia, we don't rely on opioids alone. We use multimodal analgesia, including NSAIDs, regional blocks, which are one of my personal favorites, and non-opioid adjuncts. Why? Because it improves pain control. It reduces the opioid requirement and therefore decreases the side effects from opioids. Multimodal analgesia is the future of anesthesia practice. So, to bring it all together, opioids are one of the most powerful tools in anesthesia, but with that power comes responsibility. You must understand their pharmacology, tailor them to the patient, and monitor constantly. Mastering opioids is a critical step in becoming a great anesthesia provider. And this is just the beginning, because the providers who truly excel aren't the ones who memorize drugs. They're the ones who understand how to think. So, thank you for watching another FCLS lecture with us. As always, if you have any questions or need further clarification, leave a comment or reach out to us directly. At FCLS, we're committed to helping you build the knowledge, confidence, and mindset it takes to succeed in CRNA school and beyond. Thank you.